A minute now. Hi, good afternoon, everyone, and I'm your host for the housekeeping slides. Thank you for joining us on Saturday afternoon and spending your time. And this will be the 17th SJMC Grand Round, and you can see the team at the bottom here. And before we start, I just want to go through just quickly the housekeeping slides before I pass on to the moderator, who is Dr. Jayamala. Now, please join us for discussion. You can actually ask questions on the YouTube or Facebook if you're watching from there. But you can also join us at slido.com and enter the code 199004, or just scan the QR code to get to Slido at 199004 to ask your questions. But questions will be answered only at the end of the session. Okay, and as usual, we'll have CBD points which you can claim with a QR code which is displayed at the end of the talk. All right, and you can scan this QR code with the MMA app. Now the code will be active for about an hour only, so please take note. Okay, without further ado, I'm going to pass the mic to Dr. Jayamala, who will be the moderator for the session. Dr. Jay.
Thank you very much, Alan. Okay, we'll share screen first.
You'll share your screen.
Wait a minute.
It must be reloaded.
Okay, just chest pain is a very common complaint, and we see all kinds of patients coming to us with complaining of various kinds of chest pains. And the topic today is chest pain, a diagnostic dilemma. Can you all see this? All right, fine. Okay. Now, in 2021, somewhere in April last year, the American College of Cardiology and the American Heart Association came out with this clinical practice guidelines on the evaluation and diagnosis of chest pain. It is a very comprehensive thing, and I think you should all read it. And it has some very nice algorithms of how high your index of suspicion is to be depending upon the nature of the chest pain. Okay, the first case, 30-year-old young man who comes complaining of shortness of breath. This may occur at any time, no orthopnea, no cough, no wheeze. He denies chest pains, but occasionally he says he has vague chest discomfort with a feeling like something is stuck in his throat. He claims it's better after drinking water. This sensation may occur at any time, although it may occur after his gym workout because his throat becomes dry. These were the words he used. And these symptoms occurred well before he got his booster. He's a non-smoker. He goes to the gym and he does treadmill regularly. No problems at all, he claims. His father underwent a bypass in his 50s, and he's the eldest child in the family. On examination, nothing to find. His heart rate is 62, saying that he is quite a fit person, and the blood pressure is 110 over 80. He was not overweight. Okay, firstly, Dr. Yap, what would be your differentials and what would you advise this patient?
So thanks, Dr. Jaya. This patient, I think, is not too unusual in his presentation from the kind of patients that we see in the clinic, and from the observations that you've done, he's relatively stable. So in summary, he has a presentation of breathlessness with a bit of chest discomfort. It's a little bit atypical because of this feeling of having some sensation stuck in his throat. And the unusual thing is he's young, so he's 30 years old. So my first impression is that maybe it's unlikely to be cardiac, because most of our cardiac patients are a little bit older. But in terms of his risk factors, he doesn't have hypertension, diabetes, he's a non-smoker, but he just has a family history. So I think in terms of differential diagnosis, I would class into systems. The first system being respiratory, and I would consider the possibility of infection, pulmonary embolism, or even rarely something like pneumothorax causing breathlessness in a young patient. And then the other systems that we'll consider is basically upper GI, and also then subsequently cardiac. So what I would advise the patient is basically to start with some simple tests. So let's say if I wanted to look for infection, pulmonary embolism, or even heart failure, I would do a set of blood tests. I would consider to do X-ray to look for any lung pathology, including infection, and also an ECG to screen for any acute cardiac presentation. So that's what I would advise the patient, to start with some basic tests first.
Thanks. Yeah. Okay, these were the blood tests that were done. Hemoglobin normal, renal function normal. Well, his cholesterols are not too bad last. D-dimer not raised, and NT-proBNP was normal. After the booster things, everybody wants to do a D-dimer. So it was done and it was normal. This is a chest X-ray. What do you think?
The X-ray looks normal. There is no sign of infection. There is no pneumothorax. I mean, we can't see pulmonary embolism on the X-ray. There's also no sign of fluid overload, so it doesn't look like heart failure or infection.
What about the ECG?
Well, there's no obvious ST change. The ECG shows sinus rhythm. There's a very, very slight abnormality I see is that's quite common in a young patient, which is there's a bit of like an M pattern in the V2, V1, V2, which suggests that there's a partial right bundle branch block. But I don't think that's very significant in the context of this presentation. So I would say it's basically there's no significant abnormality.
Okay. So what would you do next?
Well, I think considering the differentials, and we've looked at the respiratory, the obvious ones are not quite there. I would start with maybe some cardiac tests first, because when I see such a patient in the clinic, my responsibility is to actually make sure that there's no cardiac issue. And then if there isn't, I would probably refer to another specialist, maybe a gastroenterologist, because of this feeling of being stuck in the throat. So I will also consider upper GI possibility. So, but because it's a young patient, he's stable, I would start with the stress test, I think.
Okay. Yeah. A stress ECG was done. Kanan, would you have done a stress ECG in this patient?
Okay, let me say this. I think I would be completely lost where this patient is concerned. I think his history is very vague. I won't think of a cardiac condition at all when he first saw me. And the only thing that caused me to stop and think a little bit is he has got some history of premature coronary artery disease in his family. His father was less than 55 years old when went for bypass surgery. Other than that, in all fairness, I think looking at whatever you have presented so far, there's no reason for me to think that this man has got a cardiac problem. Yes, I would do a stress test, mainly because it's very cheap, simple to do, virtually no risk factors. But the stress test, the accuracy is dependent upon the population in which you do. This guy has got very low risk factors, so I have to expect a rather high chance of things like false positive tests. With that to consider, taking that into consideration, yes, I'll do a stress test, mainly because it is simple to do, it is non-invasive, has got no risk.
And I think Yap's reason that you have to exclude coronary artery disease since he came to see a cardiologist, I think it's not unreasonable. Okay, so a stress ECG was done, and Yap, you help us to interpret. This is the pre-test. This is after 3 minutes, after 5 minutes, and this is 5 minutes, and this is baseline. Yep, over to you.
Are you able to go back to the first slide and then the second and the third slide? So the baseline ECG we have seen doesn't show any major or significant abnormality there. So if we go to the next slide, this will be the first stage. So in the stress test, every stage is 3 minutes. We are looking to see at low initial testing whether there's any ST changes. I think there's a very slight ST change, although at this point in V5 and V6, it is not deep and it's upsloping. So I wouldn't say that there's major change so far. But if you go to the next slide, which is at 5 minutes, so if you look at the 2, 3, and AVF leads, which is the inferior leads, I see some ST depression. And more obvious, I think, is in the lateral leads in V5, V6, there is ST depression as well. So basically, if you compare certainly baseline and the peak exercise, which is in this slide, I would say that there are abnormalities that would make me think further about whether this patient does have cardiac ischemia or not. Basically, I think the stress test looks positive. Certainly on the ECG, it looks positive.
I was also a bit concerned about the ST elevation in AVR and V1. What do you think?
Yeah, I mean, I think that those are possibly reciprocal changes as well. ST depression in certain leads and other leads, you get reciprocal changes. So, I mean, it does make the stress test look abnormal.
Can I make a comment?
Sure, yes, Kanan.
Okay, I think when you do a treadmill test, we always think about false positive tests. Now, ST segment depression is not as diagnostic or as accurate as ST segment elevation. Whenever we see ST segment elevation, that's almost always 99% positive. And when you see ST segment elevation AVR, you have to worry about left main stem disease. So we cannot dismiss ST segment elevation as much as we can ST segment depression. So in this man, surprisingly, given such a vague history, this is a very positive test indicating serious coronary artery disease.
Okay, now about this time, he also complained that he was having this, he wants to drink water because his throat was feeling dry. So it looks like the symptoms could be related to what you saw on the stress test. Okay, Troy, you saw the stress test and things. What would you now advise?
Yes, thanks, Dr. Jia. So now we have a positive stress test for this patient. Like what Dr. Kannan says, sometimes stress tests we have to deal with false positive. In a patient who has a low pretest probability and a vague symptom, ends up having a positive stress test, it's not very helpful. I was hoping that it was negative, then he has a very good negative predictive value. Then we can almost rule out coronary artery disease to start with. So now he has a positive stress test, and it's a very positive stress test because there's AVR elevation, probably signifies global ischemia as stress. Symptom reproducible, that choking sensation after the stress test. So I would definitely feel that there will be a need to further investigate his coronaries. So it's just that deciding whether you want to do something invasive or something non-invasive. For him, I would suggest something non-invasive like a CT scan. CT cardiac angiogram will be quite useful at this point.
Okay, he did a CT angiogram. So the calcium score was 0. And Troy, maybe you could help interpret the findings.
Okay, so as you can see here on the screen, this is the CT coronary angiogram of the patient. If you follow Dr. Jaya's cursor, so this is the origin of the left main trunk, and there is actually a narrowing scene which constricts the opacity of the contrast over here, and this is actually where the left distal part of the left main stem is. Eyeballing, I think, is quite significant, at least 50 to 60, if not close to 80% stenosis at some angle, quite eccentric looking. This is significant, and this patient definitely has significant left main stem stenosis. Just a little bit to add about the calcium score. As you can see, his calcium score is 0. We used to think that calcium score is a very good screening test for coronary artery disease, which is actually not entirely true, especially if the patient is young. Most younger patients, they actually have a soft plug. So when you have a soft plug, even though if you have significant stenosis, the soft plug will not be able to be picked up by calcium score alone, which is evidently seen in this case because his calcium score is technically 0, despite the left vein is so tightly stenosed. So to conclude, he has a significant coronary disease, and unfortunately for him, is a left vein involvement.
The other coronaries were normal. Okay, Kannan, what would you now advise in terms of medications, revascularizations, etc.?
Okay, what we see on the CT angiogram correlates with what we saw on the treadmill. Treadmill showed ST segment elevation AVR. We are already starting to look for something in the left main, and the CT angiogram shows a left main stem disease. Now, the CT angiogram assessment of stenosis is generally not very accurate. Often what looks very severe may actually be mild. But what's important in this man is the location of the plaque. The plaque is in a very important, prognostically important site, which is the left main stem. And from what we can see, there's quite a bit of positive remodeling, quite a lot of plaque. So if this ruptures, and it may rupture, it's a soft plaque in that location, is certainly going to die. So he will certainly need medications. And in addition, he has earned a diagnostic coronary angiogram, in my opinion.
So what medications are you going?
Well, the important ones would be he'll need an antiplatelet agent. And in his case, given the location of lesion, I'll use a dual antiplatelet agent, usually aspirin and clopidogrel. He will need a statin. And given how bad the lesion looks like, we want to keep the LDL level down to about 1.5. I think this is the current recommendations. I would also probably throw in a beta blocker if he can tolerate it. And I think of all the anti-anginal agents we have, the beta blockers are the only ones that have got some prognostic benefit and not only symptomatic benefit.
Okay. So he underwent a coronary angiogram, and you can see this is the left main, circumflex, LAD, and yes, there's a narrowing there. Okay, before we see what happens, Kanan, what would you advise this patient?
I think I was in the lab with you together with Choi when we did this. I mean, certainly I see left main disease. My first recommendation to a patient is coronary artery bypass surgery. That'll be my first recommendation. And then we'll have a discussion. Something needs to be done. He needs revascularization. My strong advice first would be coronary artery bypass surgery. He's so young, so that I would ask him to find a surgeon who can do arterial grafts so that he will have very good long-term benefits.
Okay, what about Choi? And Yap? What are your? He's 31 years old. What are your thoughts? Yap first.
Yeah, and I agree with Dr. Kanan. Our first starting point is usually to consider coronary artery bypass grafting. I think to go into left main treatment and angioplasty in a little bit more detail for, it's also not unreasonable to see some patients who are young who maybe are frightened and need to be given a bit more time to consider whether they want surgery. And we have come across some patients who certainly do not want to have bypass surgery. So I think what I would do in that situation is to consider what we call a syntax score, where we actually score and see how high risk the PCI will be to the left main. And if the score is not so high, then consider whether the left main is suitable for PCI as well as an alternative. But in patients with high syntax score, that means that the risk of PCI will be very, very high. It will then be preferable to do a CABG.
Yeah, I totally agree. Nothing else to add. I think the syntax score will be very useful. Like for this patient, I guess his syntax score will be quite low. And if he has his own reasons to choose not to undergo surgery, then I would believe the next option in line will be percutaneous angioplasty for him.
Okay, basically he underwent angioplasty with stenting, and hopefully it will hold up. All right, so what are the learning points from this case? Young man, 31 years old, he claims he goes to the gym and everything, and he comes with atypical chest symptoms. There's no obvious cause for this, but he warrants some form of non-invasive testing for ischemia, especially if there's some relationship to acid. I mean, I agree, it sounds very much like reflux, something stuck in the throat. But he did have some of these symptoms when he went to the gym. As Kanan pointed out, the type of symptoms would depend upon the symptoms, pre-test probability of coronary artery disease. This man has a low risk for low pre-test probability of CAD. So if the stress test had been normal, it would be good. If it had been just some ST depression, that would be difficult. But this was ST elevation, and therefore it made the diagnosis quite limited. Shared decision making is important because a lot of people come and ask you, I want a CT angio. I don't want stress test. So it's important that we advise them about the radiation exposure, cause, etc., etc. Okay, we'll be going on to the second case. This is a 55-year-old man. Chest pain, he claims his pin pricking occurs on exertion, on walking. It can last up to half an hour. Sometimes he says it occurs while sleeping. And this has been going on for about 2 weeks. The last episode occurred the previous evening. Now, this man has a bit more risk factors. He's 55 years old, he's got diabetes, high cholesterol, and he's on medications, metformin and Lipitor. His sister had heart disease in his 60s. He's also a non-smoker and he exercises regularly. That was his blood pressure is normal. Heart rate is 60. He says that he is actually quite fit. So, based on the history, what are your thoughts, Dr. Choi? And what would you do?
Okay, so this case is a bit different from the first case. So we have here a patient with some sort of probably angina-like kind of symptom. Not too typical, but mind you, he's also diabetic, so his presentation might not be entirely the most typical one that we get. He also has quite high pre-test probability given his background history of diabetes, high cholesterol, and family history of IHT. So despite the fact that he's a very active person, functionally normal, I think we shouldn't dismiss his symptom at the first go. For me, I would at least advise for some kind of baseline blood test and also an ECG to start off with.
All right. So these were the baseline tests. His diabetes is not very good. And I guess his lipids for a diabetic, maybe not too bad lah. Now, would you do a troponin test in this patient? First, Dr. Yap and then Dr. Kannan.
Yeah, as Dr. Cha has mentioned, the history is quite typical of angina on exertion. So I think a troponin is one of the first things I would do to risk stratify. So if the troponin was positive, then we need to maybe consider revascularization more urgently. And if it's negative, then I have a bit more time. Maybe I would do some more non-invasive tests first. So yes, I would do a troponin test.
Kannan?
Okay, I would like to make one or two comments to support what Choi said. I think that any diabetic that walks into our clinic, he has got heart disease until proven otherwise. I think that should be the basic thing that we have to start the premise with so we don't miss things. In fact, diabetes by itself, if it's been there for 10 years, is considered a significant risk factor for coronary artery disease. So this man, he is definitely coronary artery disease until proven otherwise. And as far as the troponin test, yeah, I mean, he has had symptoms that went on for 30 minutes. Not unreasonable to do it at all.
All right. So an ECG was done. Choi, you can help to interpret it. Dr. Choi?
Sorry, I lost you for a while. Can you hear me?
Yes, I can hear you.
Okay, so we have a patient with a probably angina-like symptom. The baseline ECG is actually very helpful. First, we look at the heart rate. His rate looks fairly normal. He's not tachycardic. So that would exclude a lot of respiratory distress or cardiac distress related issues. It kind of like stratifies the level of severity that the patient may be having. So for example, if he's having sinus tachycardia running at about 120 beats per minute, so he will be a little bit more unstable compared to the one that we're looking at right now. So the axis of the ECG also tells a lot. So if you're worried about occult or ongoing chronic pulmonary embolism, sometimes if you're lucky, you can see a little bit of a right axial deviation with a bit of RVH and RV strain. And most importantly, of course, the ST segment, if we do see ST depression or worst case scenario, ST elevation, then we have to definitely further investigate in line of the ischemic heart disease. Now, a very interesting thing is that when you look at lead 3, there is a Q wave. over here. And not uncommon. We do see that from time to time, and sometimes it has been misinterpreted as inferior MI. But in this case, if I may comment, only one lead, you can see the Q wave over in one lead. There is no other consecutive leads that shows a Q wave. So this is actually not indicative of inferior MI, in my opinion. And also, if you do have a pathological Q wave, usually the Q wave will be broader, at least 0.04 milliseconds in width, the majority of the time. So this is actually a normal pattern in a normal ECG for this particular Q wave. And sometimes, if you were to ask the patient to breathe in and out, the Q wave, oh yeah, the Q wave may actually disappear because it has to do with the relationship of the heart. When you breathe, the axis of the heart may actually turn a little bit more vertically, and hence the Q wave will disappear for a while. So they call it the respiratory Q wave. This is actually normal Q wave.
Thanks, Todd. So this stress ECG was done, 9 minutes, 30 seconds, it was negative. Okay, Kanan, what, if anything, would you now do? What do you advise the patient?
Okay, the first thing I would like to ask is, you said that the treadmill test was negative. Was an adequate workload achieved? Because it's very important.
Yes, he achieved about 95% of his maximum heart rate.
Okay, we have to emphasize that when you do a treadmill, if you don't do an adequate workload, it may not be diagnostic, because the accuracy of the treadmill test itself is just about 70 to 75%. Now, in this man, I would think that given his history, we need to do a definitive test that enables us to see his coronary artery to conclusively exclude coronary artery disease, because he is a very high risk candidate and he has got symptoms on exertion. In the old days, we would have recommended a diagnostic coronary angiogram. Nowadays, we have got a CT angiogram, and you choose to use it mainly because preliminary test has been negative, so you don't want to subject him to an invasive test like an invasive coronary angiogram, which carries higher risk. So certainly, I will want to do at least a CT angiogram. As far as medications are concerned, yes, we have to optimize his diabetic control. Fasting glucose, we need to get it between 6 to 6.5, HbA1c about 6.5%. And certainly his LDL cholesterol, although it looks rather benign, we need to bring that down to about 1.5.
All right, the CT angiogram was performed, and Dr. Kanan maybe would like to interpret it.
Okay, what we see here is that there is a plaque. Jaya, maybe you can point. Yeah, we can see Jaya's cursor. The plaque extends from the left main into, it is only LED, right?
LED,
The other view,
yes.
look at left. So this is a plaque mainly in the left anterior descending artery. Proximal segment, distal portion of the proximal segment looks rather nasty because it's mainly a soft plaque. So we have to worry about this in a diabetic with the exertional symptoms. Yes, so he has got a significant plaque in the left anterior descending artery.
Now, if these symptoms are typical, should he have gone straight for an invasive angiogram as opposed to a CT angiogram? Yep, and then Kanan.
Well, I would say that I speak for my own practice. If I would want to do an invasive coronary angiogram, then I would think it would be in the context of either a patient with symptoms who is troponin positive, or positive stress test, or if they have some evidence of coronary artery disease on a CT scan. So I probably would still go for a CT angiogram if the troponin was negative, but if the troponin was positive, then yes, I would go for invasive coronary angiogram.
Kanan?
You know, I'm very conservative, but in a diabetic with symptoms and exertion, I would have very little hesitation to doing an invasive coronary angiogram.
Okay, all right. So differences is opinion. So this is where you need to discuss with the patient, put it forward, the pros and cons, so that he can help to make the decision. Some may decide to go straight away for the invasive, saving costs, and you can settle it once and for all if there really is something. So it's a discussion.
I would like to make an additional point. Although we do a lot of CT angiograms, and although CT angiogram interpretation accuracy has increased, there's still a small proportion of patients where we can miss a lesion for one reason or the other. So if you do a CT angiogram in this man and say the CT angiogram does not show anything significant, I'll be very uncomfortable to send him home because he's diabetic, he's got major risk factors, he has got symptoms and exertion. I'll want the acid test to be done. That's my argument.
Okay. Choi, would you have to add anything there?
Oh no, I think I usually let the patient, like you say, we discuss with the patient first, the pros and cons, and sometimes I guess we can meet in the middle, either a CT or invasive angio.
Okay. The next question, what do you feel is the role of the following tests in cardiac assessment in asymptomatic individuals as happens during health screening? Exercise stress testing, calcium score, CT coronary angiogram. First Choi, then Yap, and then Kanan.
So for me, most important thing is you look at the asymptomatic individuals. So they come here for health screening because the package is good. They end up doing blood tests and sometimes exercise stress testing as well. So I go one by one. So for stress test, like I mentioned earlier, it has a very good negative predictive value. So it's excellent when the result is negative. You can safely tell the patient that most likely there is no significant ischemic heart disease at this point. Unfortunately, especially for the female patients, I think there's quite a degree of false positive incidents that we do see from time to time. Then we have to go back to the pretest probability to see how much further do we need to evaluate. And regarding the calcium score, which is quite interesting because recently, I think a lot of these larger cohort studies happen to publish that calcium score itself is an independent predictive predictor actually for CV event. So when you have a patient who has this lipidemia, asymptomatic, technically quite a low risk patient, but the cholesterol is high, I think calcium score can be a good modality to further guide us whether the patient needs statin or not. So if the calcium score is high, I think probably like 100 and above, then in the context of this lipidemia, starting statin, in my opinion, would be beneficial, but probably not the other way around. So if a patient has a very low calcium score, like maybe less than 10, and even though you have very deranged lipids in a patient with low risk, I think starting statin at that point might not be too beneficial. These are my two opinions.
Yep.
Yeah, I think we are talking about patients who are asymptomatic here. And I would say that for majority of patients who are asymptomatic, it clearly depends on the risk profile. In a young patient without any risk factors, clearly stress testing is more than adequate. But in older patients with cardiac risk factors, we need to start to think whether they need a bit more in-depth assessment, especially given the knowledge that diabetic patients, as Dr. Kana has mentioned, diabetic patients are high risk and they may have no symptoms even though they have cardiac ischemia. So I would consider patients with older age group, male, those with diabetics, heavy smokers, or strong family risk history for CT coronary angiogram. Just the other day, where I was doing health screening, and a patient was actually saying, I just have a colleague who did a stress test with a health screening in one center, and within the next week, dropped dead. You see, what's the point of having a health screening and just doing a stress test and not picking up that this patient has coronary artery disease? Now we are going to actually go back to that hospital and think about suing the hospital because we came for your check and you didn't find out. So I think one there are scenarios where probably we can consider to go into a little bit more depth, as I said, depending on the risk profile of the patient.
Okay, Kanan.
I think this is very difficult, increasingly more difficult because we have got many options. Now, I think little for me to add to what Dr. Choi and Dr. Yap have already said. I want to, there's something that Choi mentioned that I'm not very clear about. I think he said that if you have got somebody with dyslipidemia and if you do a calcium score and the calcium score is not high, may not be necessary to start lipid treatment. Did I get that right? Choi?
Yeah, I mean, we look at the recent cohort studies. It shows that if you have a patient with high calcium score, the predictive value is much higher as opposed to a patient with a very low calcium score in terms of atherosclerotic CV event in the future.
That I would agree. But suppose somebody has got significant dyslipidemia and then you did a calcium score and the calcium score is low. Would that necessarily be a reason for you not to start lipid lowering therapy?
It depends on this overall 10-year CV risk. If it's more than 10%, I think we should still put them on the statin.
Okay.
But I guess for those who have more of a borderline or lower 10-year risk, CV risk, and we don't know whether we should put them on the statin or not, maybe the calcium score can further stratify these patients for us.
That I absolutely agree with you. But if somebody has got significant hyperlipidemia, the calcium score or whatever we are doing is just an examination at that point in time. Untreated over the next couple of years, the dyslipidemia may cause trouble for you. Now, in terms of choice, somebody comes in asymptomatic, is asking for a cardiac evaluation. Do I do a treadmill test, which is old-fashioned? We know what are the limitations, we know what are the benefits, or do I go straight to a CT angiogram? I think this is where we need to sit down and discuss with the patient and tell them what we know today. I mean, this unfortunate person who went to that medical center had a treadmill test done. Presumably, it was well done, adequate workload, and nothing happened, and he went home to die. I mean, he could have had a minor plaque, which unfortunately ruptured, which all of us have seen. So, when we have a discussion with our patients after the evaluation, in someone who's asymptomatic, has got borderline risk factors to do a treadmill test, and the treadmill test is negative, we have to explain to them, yes, your treadmill test is negative, so prognosis-wise, this is good, but our new knowledge is you could still have minor plaques in your heart arteries, which we may not have picked up. This can still give rise to trouble. This doesn't necessarily mean that you won't have a heart attack. I mean, that has to be said so that in a sense you cover yourself. This kind of defensive medicine business. And if they say that, well, in that case, doctor, I would like to have something else, the CT angiogram that then perhaps you have to do. But you can be very unlucky, you do a CT angiogram, you either see a minor plaque or you don't see the plaque, and you say everything is okay, he goes home and drops dead, they come back to see you too. So I think all this has to be, like we are discussing in this webinar, it's a joint decision, explaining to the patient what our limitations are, what the investigation's limitations are, so that they understand as well.
Thank you. So that you all can see what is the role of the different diagnostic tests in the evaluation in an asymptomatic individual. Okay, so this is what happens to the patient. Okay, that was the lesion. And another view of the lesion. And yes, he went ahead and instead. Okay, so is there a need for further testing to determine the significance of this lesion if it were less severe? I think this one is quite obvious. What if it was less severe? Would you have done it? I mean, it's got some symptoms.
You're saying that you do an angiogram and the lesion looks less.
Yeah, maybe it was.
Is that what you're saying?
Yeah, 60%.
I think these are the days that we do an FFR to see what it is like and then take it from there.
Okay, so if it was less severe, you would have like to have some indication that it's severe, especially if it is borderline.
Yeah, either that or call them around the phone, ask her to see the angiogram. And
okay. All right. So the chest symptoms should correlate with the severity of the lesion seen. I think that's a take-home message as well. Okay, we'll go on to the last case. This is a very short case. A 63-year-old man, after lunch, ate biryani, felt epigastric and chest congestion, had some sweating and shortness of breath, denied chest pain, better after burping. The whole thing lasted half an hour. After felt better. He's diabetic, on Daonil and metformin. There's no family history of heart disease. Both parents had diabetes and died in their 80s. He doesn't smoke and he doesn't exercise. So, with that history, he went to see his family doctor. The family doctor listened to the history and said, I'm sorry, my ECG is spoiled. Please go to the hospital. So he went home since he felt okay. The family were not happy. They said, you must go and do an ECG. So they went to another clinic. An ECG was done and it was told to be normal. Okay. So at 11 p.m., he had a recurrence of the chest congestion. This time it did not get better. So they came to the hospital at 5:30 in the morning. Heart rate 68, BP 120/80, and he was not in failure. So, yeah, what do you think of this ECG?
Yeah, thanks, Dr. Yat. The history of this man, 63 years old, diabetic, whose clinical presentation is a bit like gastric symptoms also, where he even took some eno. So I think it's not uncommon because I've seen a few cases of acute coronary syndromes where the patients were very, very sure that they had gastric. And then when they came to the ER, they had ECG changes. And that's when the ER MO will refer to us. So the ECG basically shows sinus rhythm, and there are ST changes. In particular, I think the most marked is in lead 3 and lead AVF. So the inferior leads 2, 3, and AVF all have ST elevation, and this would indicate an acute inferior myocardial infarction. In addition, actually, the patient is now starting to have Q waves. So we were talking about Q waves in the earlier scenario, which were in one lead, not significant. Here you start to see Q waves forming in lead 3 and AVF in 2 leads already. So this is where it's an example where it's significant. And then there is also some reciprocal change as well, the SC depression in V2 and V3, which we will see in the acute myocardial infarction. So this is an ECG showing acute MI, inferior MI.
Okay. So which artery do you think is a culprit vessel, Choi?
Okay. I would like to add a little bit. I guess I can understand why it was reported to be normal initially at the clinic level, because sometimes MI, when you were to do an ECG a bit too soon, the QAs have not formed yet. And for inferior MI, somehow our eyes are not well trained to pick up that subtle ST elevation, which could be present at the very early phase of the MI. That's why commonly it's actually misdiagnosed actually. But one thing I can add is that sometimes when you see a patient which has pain and you look really hard and you can't see any ST elevation, probably a more reliable ST segment change would actually be the AVL, which is the reciprocal ST depression. I can say almost 99% of the time in an inferior MI, the AVL ST depression will always be there if we look hard enough. So, I mean, to all the doctors at the clinic level, if you were to do an ECG, not just pay attention to the ST segment elevation, but just look at AVL. In inferior MI, usually there will be some kind of ST segment depression or T wave flattening. Coming back to this question, which artery the culprit vessel? So he has an inferior MI, so it could either be a right coronary artery that supplies the inferior wall, or it could be a left circumflex dominant artery. So the question is, which one? To me, when you look at all these algorithms, people talk about lead 3 higher ST segment elevation or lead 2 higher. I personally find it very difficult to use because most of the time I fail. I guess it's right, it turns out to be left. But for this particular patient, if you look at V3, So the B3 ST depression is actually quite deep. For me personally, I find this a very accurate way to predict. If the ST depression in the B3 almost matches the ST elevation in lead 3, usually it is not the right coronary artery. Because if you have a right coronary artery occlusion, the RV wall will usually be affected. So you have a lot of strain, a lot of ischemia on the right ventricular wall, which is actually probably just above the lead 3. So whatever happens, it should be more towards the right side. So when you see something that matches V3 and lead 3, I think it's more of a circumflex. But I have to say, sometimes our guess can be quite wrong. What about the others? What do you think?
Okay, maybe because the interest of time, I'll just go. Okay, you're right, Troy. It was a acute circumflex occlusion, and that was open. Okay, all right. So this was his first specimen. When he came to admission at 5:30, CKMB is actually normal. TRUP-T slightly elevated. The second specimen, the CKMB went up, 38.2. And these were his cholesterol levels. As Kanan kept on saying, the LDL is too high for him. Okay, can you comment on the blood results with regards to the discrepancy between the history of chest symptoms and the enzyme rise? Yeah?
Yeah, we know that when chest pain first occurs or MI first occurs, the cardiac enzyme will be normal. The cardiac enzymes usually starts to rise after a few hours, specifically should be around 12 hours. And they generally peak around 24 hours. So if you look at this set of blood tests, it makes sense that the initial CKMB is normal and the peak is actually about 10 times the level is at 24 hours.
Right. So there was a mild hypokinesia, EF not. What medications would you send this patient home with? Yeah.
So now there's a generally standard set of medications we should consider in anyone who has had a myocardial infarction with evidence of some myocardial damage on the echo. So going back to the echo, it actually shows some mild left ventricular dysfunction. So first of all, we are talking about obviously antiplatelet drugs. So we start with aspirin if they're not allergic to aspirin, and either nowadays Brilinta or Plavix, the two medications, and it's recommended to continue the two antiplatelets for up to a year. So that's the first group. Second group is beta blocker. So I would consider starting a small dose of maybe bisoprolol, Concor, as tolerated by the blood pressure and the heart rate. The third would be a ACE inhibitor, or if the patient is not able to tolerate an ACE inhibitor because of side effects, maybe a angiotensin receptor blocker. So maybe you consider perindopril or something like valsartan. And then the last group will be statins. So certainly, as we've talked about already, we need to control their LDL up to now recommended as low as possible, up to about less than 1.7 LDL. So those are the four medications I would send the patient home with.
Thanks. So what advice would you give this patient regarding physical activity, climbing stairs? I got stairs in my house, driving, Troy and then Kanan.
For me, I guess symptom is very important. If the patient is still symptomatic, you shouldn't overexert. But objectively, I will put him on the treadmill after a month. Before I would say he should go back to his exercise or strenuous activity. Driving, our CPG 2019 managing STEMI, it's stated there if you're a private driver, it should be a month if it's uncomplicated. If you do commercial driving, it should be 3 months and above if it's uncomplicated and if your stress test is acceptable.
Kanan, you have anything to add?
Nothing actually.
Okay. All right. So the last learning point, be inquisitive when a patient suddenly turns up and wants to do an ECG. sometimes they don't tell you that they had symptoms. They will just say, I feel okay, I want to check up, I want to do an ECG. So sometimes you must dig the history, because if you had the history, you'll be more vigilant when you look at the ECG. And always remember, gastric symptoms can mimic MI. Okay, and I think we have just in time. Pass it over back to Ellen.
Okay, thanks, Yamala. Hang on, I'll move on to questions, yeah? So, see, any questions on Slido? No questions on Slido. Any questions on YouTube? I think everybody was crystal clear. No questions on YouTube either.
Can I say something since there are no questions?
Yes.
Yes.
Okay, this is about ECGs in patients who present with chest pain. Over and over again, we have seen, although not very frequently, patients who have had uh, myocardial infarction. Some of them have been admitted to hospital because the symptoms are very suggestive and we suspect acute coronary syndrome. When they get chest pains, you find that there's ST segment elevation. And within a matter of minutes, the ST segment goes back to normal. So it's a combination of an unstable plaque where thrombus forms and autolysis and coronary artery spasm which gets relieved. So somebody could present with pain, go to your clinic. By the time he comes, the pain has completely gone. The ECG can look normal. So the thing that you have to fall back on is the history alone. In this man, he is diabetic. There is sweating. Any sweating in a diabetic, we have to pay attention to, especially with the complaint of chest congestion. So a normal ECG doesn't exclude something very important.
All right. I think so. No questions. We're either very good or everybody is very confused.
Maybe chest pain is expert. Everybody's expert in chest pain. Yeah. Maybe we'll show the point here.
Okay.
Okay. So these are the this is the QR code for claiming the points. Let me move it out of the way.
Thank you very much, Ellen, and thank you very much, all of you, for listening in. And thank you for Yap, Choi, and Kanan. Thank you very much.
Yeah, that is fine. Okay.
All right. So, suddenly this guy started.
Okay, so I'll leave the broadcast on for a while. You guys can take a break.
Yeah, so I mean, if you mute it, I think next time tell this guy.